Hello, everybody. I'm here at Dante Pazanese again, team of physicians. Dimitri Siqueira, as you know, is here in my left. He's going to be the first operator for this case. Ricardo Costa, you also know. So, Dimitri, you have the slides. Can we
Yes,
go
yes,
direct to the
Fausto.
case? Okay.
Thank you, Fausto. Let me present our patient for today. This is a 83-year-old lady, non-frail, independent. She has a high BSA and a past medical history. She has hypertension, dyslipidemia, and a permanent pacemaker. This patient presented to our hospital with symptoms of heart failure due to aortic stenosis, and on perioperative risk assessment, the Euroscore 2 is 1.3 and the STS score 3.4. So she was deemed a low-risk patient for surgery. These lab tests can appreciate she has a normal renal function with a GFR of 86. The BNP is mildly elevated. She has permanent pacemaker, like we said before. He's on pacemaker rhythm on the EKG. And the echo findings you can appreciate here. She has a preserved LV function with ejection fraction of 62. She has a mild mitral regurgitation and a moderate mitral stenosis with mitral valve area or 1.7. The aortic valve is calcified with a mean gradient of 43 millimeters of mercury and an estimated aortic valve area of 0.6 square centimeters. This is the CT workup. She has a small annulus with a perimeter of 67.5 millimeters. The Valsalva sinus diameters are 28, 29, and 29. And she has a tricuspid calcified aortic valve with a calcium score of 1060, around 600. And here you can appreciate the STJ, the measurement. The ascending aorta is not dilated. We proceed with a detailed analysis of the left main distance and also the left coronary cusp. And you can appreciate here, as I said, he has a low coronary takeoff on the left. The VTC is around 4.5, and the calcium volume at the left leaflet is below 600 millimeters square. So here she has, let's say, moderate risk of coronary obstruction. These are the angulations, the estimated projections that we're going to use for valve deployment. And on CT reconstruction of the iliacs and femorals, he has good diameters, some tortuosity on the right, and a high femoral bifurcation on the left. And we also proceed with analysis of the aortic arch and branches, just to evaluate the anatomical suitability for the use of Sentinel device. In summary, 83 lady with severe symptomatic aortic stenosis, non-frail, low surgical risk based on the scores, and some anatomical challenges for TAVR low coronary takeoff.
So you mentioned she has mitral stenosis. Do you think the cause of this is only calcification in the senile calcification, old calcification?
It seems that it's a degenerative mitral stenosis, but we investigated with echo and by experienced operators, and she has a moderate mitral stenosis,
Okay.
so no
She's
aortic
she's
stenosis.
a small lady. She's only 145 centimeters, but at the same time she's obese. because she has 85 kilograms.
Yeah.
So is
This
there
is a,
any
this is a,
specific comments about
yeah,
this?
this is an important issue because she has also a small annulus.
Mm-hmm.
So she has some risk of PPM, of
Uh-huh.
patient-prosthesis mismatch.
Mm.
And our plan is to use a self-expandable valve just to get good hemodynamics post-procedure.
So in this situation, she has a small annulus, like we mentioned. She's only 145 centimeters, and she also has a low coronary takeoff
Hmm.
of the mainly the left. It's 8.5. Is there any specific consideration to choose a self-expandable valve because of this or not?
Yeah, particularly in this case, we choose an accurate NEW2 valve. I'm going to show some slides that can corroborate my opinion here. This valve has a low, very low incidence. In fact, no case
Has reported.
have reported so far in the literature with coronary occlusion after the accurate NEW2.
Do you want to show the accurate right now, or do you want to show what you have done so far?
Maybe we can show our strategy here
Okay,
for
yes,
today
yeah.
and proceed with sentinel implantation.
Yes, great.
So we're gonna perform this case in conscious sedation with a minimalist approach.
So what is your experience in here with the minimalist approach? Do you discharge the patient the next day? They usually don't go to the CCU or something like this?
Yeah, in our experience, majority of patients, let's say 80% of cases, they are discharged next day.
Okay, great.
So maybe Ricardo can show also what we did so far here.
Ricardo, please.
Yeah, so here we have already with vascular access in the right femoral artery. That's when we have the delivery system, the iSleeve, which is already in place. It's a 14 French dedicated device to advance the valve. So it's already in place here, and we have a guide wire in position so we can advance with AL1 to cross the valve, what we want to do live.
Okay.
Here on the left femoral artery, we have a 5 French sheath, and we have a pigtail which is going to be placed.
So both punctures were guided
valve.
by ultrasound?
Both were puncture guided by ultrasound, which is our routine as well. And also we have here in the right radial, we have a sheath positioned here that we want to also demonstrate and advance, which is perhaps one of the great innovations nowadays in terms of improving the safety of the procedure, which is to advance a cerebral protection device.
We're going to deploy the first filter, the proximal one.
Okay.
So there's a slider here on the handle, number one slider.
Okay.
And I'm going to unsheath the proximal filter.
The proximal filter is going to open there.
Okay.
Which level should you open that, Dimitri?
We did an angel before, and we have also the CT. The first filter should be below that calcium that we see on fluoroscopy.
Okay.
And we should not advance the filter to the aorta.
Okay.
You like it?
Yeah. Just being well deployed. I think there's some good news in this trial that the rates of disabling stroke were very, very small. But when we take only disabling stroke alone, we could see a significant benefit.
Okay.
So if you think for one patient that happens becomes 100%.
Okay.
So I think if you can use it, of course, you enhancing the safety of the procedure.
Great. So what are you doing, Dimitri, now?
So I'm gonna try to orientate the tip of the sentinel
to the
great left carotid.
That's a great demonstration. Great. So there is the tortuosity. Oh, no, I need to go up. It's right here.
Yeah, they're very close. It's like overlap, you know, the right,
no, I think
the left subclavian and the carotid. Oh, now you're there. I think now you're there.
Yeah. Yes.
Now you're there.
You got.
Yeah.
Great.
So
now you're advancing the system.
Yeah.
So you have the wire, the guide wire in the left carotid artery.
So
now, yes,
you're
great.
advancing off. Okay.
Good
So
job.
Very elegant demonstration.
Yeah. Yes.
Yeah.
When you have some difficult, you need to be calm and just going clockwise and clockwise,
Yeah.
very patient.
Okay.
Now we are bringing the Amplatz catheter with the guide wire, it's 35 straight.
Straight, short. So
Short.
we want to first cross,
Okay.
and then we're gonna advance the AL and Platts AL1, and then we like to exchange for a pigtail to do to measure the gradient. In this manipulation, even a diagnostic cat, if you're not very careful, you can cause embolization
Yes,
and cause a stroke. So
definitely.
this is something we teach our fellows to be very, very
So,
careful.
so as you saw, Dimitri changed the position of the view. In his view, he was working in LAO. Now he is almost in the PA and the posterior anterior, or AP.
Yeah.
Now
And
to
you
get
see
across the valve.
and you see some degree of
Yeah,
aortic insufficiency and
yeah.
keeps like bringing the leaflets up. Here we have illustration of this valve and have some interesting features. It's very stable, improved hemodynamic, it's very easy to use, very predictable, and also some enhancements here with this new version, this radial pack positional markers for the placement accuracy and also a most accurate commissure alignment, as well as the outer skirt to prevent paravalvular leak.
So after crossing, Fausto, we always exchange the Amplatz catheter to a pigtail just to measure hemodynamics. And you can see, but here we had a gradient about 70 millimeters per mercury.
You can see the hemodynamics. Now can we go back to the Dimitri hand? So at this point, Ricardo is helping Dimitri to take the wire out, I mean the pigtail out, and he's gonna keeping the stiff wire over there with that special curve. What kind of
Yeah, this
wire?
is the Safari Exo
Safari.
Small. She has a small left ventricular cavity.
Balloon.
Do you like this position? Can you
Yes,
make some
yes,
comments?
I think so. We always position in RAO projection just to make sure that the tip of the catheter is in the apex of the left ventricle.
So now we are going to proceed with the predilation.
Yeah.
So when you implant accurate, you always need to predilation or can do direct implantation?
So it's highly recommended that you predilate.
Predilate.
We predilate in the majority of cases. Let's see the angel just to see how the balloon expands. I think it was a good predilation.
Okay. So do you see anything different, Vanessa, in the echo?
No,
Everything is fine?
it's okay.
Okay.
So in this valve, we have a upper crown that it's a supraannular position anchoring, and then you have the lower crown where you have the valve itself. As we mentioned, we're going to demonstrate it's a very user-friendly delivery, very stable, that improves the hemodynamics very rapidly, and we have in size of small, medium, and large. So in this case, we're going to go with
the
small.
Right? It's important to keep the wire on the greater curvature of the aorta, just to get a precise positioning of the valve.
And just to show here, so this is the safety port and the flushing port. They need to be like looking down here, 6 o'clock, to get the commissure alignment.
And then we're gonna use the cusp overlap projection, that is 36 RAO.
The position
RAO.
already guarantees a good position, but now that's a final adjustment, right, for the commissure alignment.
Just to explain the audience. So the mark is exactly in
At the
position,
bottom of the pigtail, at the annulus.
Okay.
So we're gonna start the deployment
So
here.
I'm starting here. I'm rotating here counterclockwise.
Okay.
You don't have to be fast here. See, the
Patient-
patient has very stable hemodynamics, and we're expecting here is to open the
Okay. Open the first
open
now.
the upper crown.
Let's
upper
do
crown.
another injection here,
And
Ricardo.
this is the position, Fausto. You can still have the final adjustment here.
Okay.
Okay.
Another
Injector.
Okay. Injection.
Okay. Looks good. So this is the same position that we started.
Tô fazendo.
Continue.
Só um
So
pouquinho.
unclockwise again.
I'm doing some forward pressure here.
And I'm continue here.
Uh-huh.
Okay.
Let's release the stabilization arts.
Okay, you are keeping like you're implanting a coronary stent. You are just keeping with your left hand. The mid left hand is just holding
Okay.
and pushing
So-
a little bit.
So it's
You
all-
notice that the valve centralized in the annulus.
So
So it's, I
Looks
think
like a
it's,
good position.
it's still in the same position you started. You
Yeah.
did a very nice job here. Yeah, the marker, if you can observe, is exactly the point we started
Yeah.
in the pigtail position. So
very stable.
very stable.
And the patient is
So
very stable too.
we try to correct the parallax here, Ricardo, just before the final deployment.
Okay.
So Ricardo is going to remove
So
the safety
Here's
button.
a safety button here that you just
Okay.
press and you remove this. And now
We're going to rotate quickly
it's
the knob
it's a
tube.
faster rotation here.
Okay. All right.
Okay.
So go all up the end and the valve is released.
Okay.
So patient is very stable.
Great
And
demonstration.
we're gonna check the echo now. As Vanessa is checking the echo, we're gonna do the resheet of the system.
So start with the,
So start with knob 2, rotating clockwise.
so I'm
And
doing
we can
here,
see here the nose cone moving backwards to the stent holder.
okay.
Okay. And then knob 1. And the two radiopaque
So go up to
structure.
the marker, right?
Okay.
Yeah, just up to the marker.
Like you are capturing
Yeah.
the nose cone.
Yeah.
That's great.
Resheathing.
That's
Yeah.
great.
Yeah.
So
And
now,
now
your
we can
position.
remove the system from the body. So Vanessa, how it seems on echo?
I think it's very good. It has no leak or little leak paravalvular.
The paper you published 4 years ago in the CCI and talking about 104 cases that you have done here, what is the incidence of post dilation? Do you remember that?
Let's say 30% of cases.
30% of cases.
And on that experience, we are using the previous version of the Accurate, the Accurate New 2.
Okay.
So without a skirt. So
Okay.
at that time, paravalvular leak rate was higher than we see today.
So do you think the skirt helps to
A lot,
avoid?
a lot.
Okay, now you're showing the echo. The echo looks good. What is the gradient, Vanessa?
So this is the little leak paravalvular,
Uh-huh.
and the gradient I estimate a medium gradient of 11 millimeters of mercury,
Uh-huh.
and the no pericardial effusion,
Okay, great.
and the contractility is normal.
And also, just to say, that's a recent presentation at the EuroPCR with this valve up to 5 years follow-up, 120 patients. Very similar profile of this patient, mean age about 85. And the rate of pacemaker, the new pacemaker was 13.3%. But importantly, most of these patients, they have previous EKG disorders.
Okay.
When we don't have, that's about 6-7%. That's what we see in practice.
Dimitri is just checking the gradient. What was the gradient here by hemodynamics, Dimitri?
Around 6
6. The maximum?
peak gradient of 6, 5, 6. And let's do an angel here.
So when you measure the gradient and immediately after you deploy the valve, it's a little bit higher than you can measure like 30
Definitely,
minutes
yeah.
later.
If you wait some minutes,
Have you
let's say
studied that?
10 to 15 minutes,
okay,
it's possibly
great.
that this gradient
This is
going.
very important. The hemodynamics change over time.
Okay,
In the
okay.
next day, 30 days, 1 year.
Absolutely great. You have some struts pretty close to the left main, but you were
Yeah.
quite sure that even with 8.5 millimeter distance.
But I think, Fausto, that we got commissural alignment,
Uh-huh.
as you can see here.
Uh-huh.
But in terms of regurgitation, I think fine, right?
Great.
Good position.
We're very good.
Coronaries are
So and also
patent,
also the gradient
low
is good.
gradient.
Yeah.
So what are you doing? Are going to do now?
So
So we're
Dimitri-
gonna remove the Sentinel device. We are pulling the slider number 3 just to
you put in the filter and
resheath
you
the distal filter.
retrieve and resheathing.
And then we're gonna rotate here just to try to make it straight.
Very important to do that. What when we are doing, like when we are pulling back the catheter with the thromboaspiration,
Yes.
sometimes you can get some embolization.
Yeah.
So that's very important what Dimitri is doing right now. Very carefully removing the sentinel.
Okay. And then we're gonna
good demonstration.
use the first slider.
And
Just
now you're
to
doing the same
capture-
thing with the second light. Okay,
Yeah.
very
Okay.
nicely demonstrated. So now you can just pull with a wire together, right?
Yeah.
Everything together.
Okay, great. So now we have the sentinel here.
We're gonna remove the eye sleeve, the sheet,
So now
So-
the dedicated eye sleeve, we're going to remove it.
leave the wire. We're gonna leave the wire. Just if we need another
Okay.
prog light, we're gonna. Pode tirar.
So Ricardo is just taking.
We always try
introducer?
to get hemostasis with one prog light, and if needed, we can place another one or on an angel seal.
Is exactly what you're doing now, and closing the femoral artery with only one prog light.
One prog line.
20 to 30% of cases we need another hemostasis device, a closure
So
device.
70%, at least 70% of them, we use only one prog
So
light.
it's a safe approach. Yeah, you can use a second if you need it.
See, Michelle?
Now Michelle is doing the compression. And how about the left? So you do an injection now, just to
Yeah, at the end we always check if there
check.
is
The contralateral and make
complications.
sure that everything's fine.
Let's see.
so you're
Vamos tirar?
sure that-
Vê que está sangrando. Vê se está sangrando.
see,
You see?
only one prog light is perfect, just perfect.
Perfect.
Dimitri, so we have finished this procedure. It was pretty safe. In 1 hour, we have been working with this. Now we are going to move to the next lab. Lab 1, you have a very nice case to demonstrate. I'll meet you there, maybe in 5 or 10 minutes, Dimitri.
Okay.
Thank you.